Good morning. It's a rowdy crowd today. All right, good morning and welcome to Palliative Care and Geriatrics Grand Rounds. Welcome to everyone here in the Ether Dome, to those at Dana-Farber, Care Dimensions, and Cooley Dickinson watching from afar. I'm B.R. Daubman, I'm the course director, and it's my privilege today to introduce our guest speakers this morning for one of our most highly requested topics this year. Dr. Gregory Lewis started his career at MGH in 1999, training here in internal medicine and cardiology, teaching as chief resident, and then finally serving as cardiology attending, providing clinical care to patients with a broad range of cardiovascular diseases. He's published over 80 manuscripts in fields ranging from the evaluation of novel therapies for heart failure to mechanisms of exercise intolerance and cardiovascular disease. Through metabolic profiling of human plasma at rest and during exercise, in collaboration with the Broad Institute, Dr. Lewis's group has established metabolic signatures of cardiovascular disease states that may help us refine current phenotyping approaches. The cardiopulmonary exercise laboratory that Dr. Lewis directs focuses on clinical evaluation of patients with shortness of breath of unclear etiology through comprehensive evaluation of each organ system's contribution to reduced functional capacity. Dr. Lewis also serves as medical director of the Mechanical Circulatory Support and Cardiology Intensive Care Unit and has a strong interest in the treatment of advanced heart failure and other critical illnesses. Next, I'd like to welcome Natasha Lever, a nurse practitioner in the Advanced Heart Failure and Cardiac Transplant Services. Natasha began her career working in the ICU, first at Yale in the MICU and then in the MGH Cardiac Surgical ICU. For the last year and a half, she's been working with the heart failure and transplant team, where she follows patients throughout their course in both the inpatient and outpatient settings. Her research and administrative role focuses on improving processes to formalize advanced directive planning and ascertain patient preferences in advanced heart failure clinical practice. Natasha has led the development of a systematic approach to initiating home inotrope therapy, which included goals of care discussions with patients and families and expectation setting. She's involved in several research projects evaluating the role of these therapies in contemporary heart failure practice. She will be attending PCEP, our Palliative Care and Education Practice course, next week to obtain further training in applying palliative care principles to her clinical practice. Please join me in welcoming them.
Okay, thank you for the kind introduction. It's really a pleasure to be here this morning at Palliative Care Grand Rounds. It's, I think, a great opportunity to further catalyze the relationship between the heart failure service and the palliative care service here at MGH. I am a brief opening act for the stars of the show here today, who are going to be Natasha, who's really helped us spearhead our home inotrope program. I also want to recognize some of the people that actually implement that program. So Maria Swan and Lori Rigi here, who actually take care of these patients when they're on home inotropes, along with a lot of other people within our section. And I also want to introduce Cindy Servino, who's the spouse of one of our beloved patients who we're going to hear some more about today. And here he is. This is Aldo Servino, who is somebody who's struggled with cardiovascular disease, you can see, since the mid-1980s, when he had his first myocardial infarction, which then led to an ischemic cardiomyopathy, advanced heart failure, aortic stenosis, and diabetes. And it was in that context in which he was the recipient of palliative care, as well as home inotropic support for his advanced heart failure as a patient here at MGH. So we're going to have a busy agenda for this morning. I'm going to give a very brief overview of where we are with heart failure management in 2018, as well as treatment options and ways in which we can think about how to prognosticate these patients. And then Natasha is going to take over and talk about the home inotrope program that she's helped to develop. And we'll talk about Aldo Servino in some more detail as a recipient of that care. And then Cindy's going to tell us a little bit more about Aldo's journey. So by way of, I typically confine my epidemiology slides to just one. So there's one epidemiology slide here, and it shows the prevalence of heart failure and the rising prevalence. This is probably making Judy Silva cringe a little bit in the front row there in terms of the patients on the cardiac access unit. But this is the reality of heart failure in terms of the number of cases. There's over 1 million annual hospitalizations for heart failure. Once somebody is hospitalized for heart failure, there's a 10% mortality at 30 days. There's a 22% mortality at 1 year. The challenge is we oftentimes have difficulty understanding who those 22% of people are going to be. And I'll talk about that in some more detail. We admit over 1,400 patients a year to MGH with the diagnosis of heart failure. At any given time, there's about 100 patients admitted to MGH with the diagnosis of heart failure. Heart failure is very different than a lot of other cardiovascular diseases. For coronary artery disease, for example, there is 7 office visits for every 1 hospitalization. And for heart failure, it's very different. It's an almost 1-to-1 relationship. And so these patients are in and out of the hospital very frequently. And again, we are always trying to do a better job of understanding the trajectory of these patients over time. And that's what led us to entitle this morning's talk, The Undulating Course of Heart Failure, because these patients often get very sick and then they bounce back. And then finally, the overwhelming costs of this condition estimated to be $70 billion by 2030. So even if you're not that interested in heart failure, it's going to cost about $250 per US citizen to take care of the condition by 2030. So we're going to focus on advanced heart failure over the course of the next 45 minutes. And you can see from this slide that there are a lot of patients that fall into this New York Heart Association class 3B or 4. So these are patients that have symptoms at rest, getting dressed in the morning, and doing minimal physical activity. And while we spend a lot of our time and effort looking at patients for heart transplantation, and thanks to the person who just walked in, Dave D'Alessandro and Masaki, we do about 1% of the world's transplants here at MGH as of last year and this year. But unfortunately, this is a therapy that very few patients end up receiving. You can see with the growing prevalence of heart failure, in the early 1990s, about 1 in 1,000 patients who have heart failure ended up getting a heart transplant here in the US. And as the incidence grows, that number continues to shrink. 1 in 2,000 now, and it'll continue to get smaller and smaller. So Lynn Stevenson once was quoted as saying, "A plan to treat heart failure with transplantation is like a plan to treat poverty with the lottery," in terms of the number of people who receive this therapy. And I mentioned this undulating course of heart failure, and I think this is one of the challenges with the application of palliative care in this specialty, because we oftentimes meet patients when they are very close to death upon their initial presentation with this condition of heart failure. And they're very sick when they first come in. Their ejection fractions may be 10 or 15%, and then they oftentimes have these remarkable rebounds. And then they go into this kind of plateau phase of their heart failure. And this plateau phase can last for a very long time in some of these patients. And a lot of our efforts are around extending this period for as long as possible. And then a typical course is marked by decompensations and heart failure hospitalizations. And then patients will oftentimes recover, but they'll only recover partially. And then we oftentimes will care for them in this course where they're up and down with more advanced forms of heart failure. And in that context, it's challenging to prognosticate how these patients are going to do in the coming weeks and months. We oftentimes pay a lot of attention to the ejection fraction, particularly among the trainees here. And it turns out for understanding how a patient with heart failure is going to do over time, the ejection fraction doesn't help us all that much. The size of the heart is probably much more important in terms of thinking about patients that have massively enlarged hearts. Those are patients that are much less likely to get better over time. And fortunately, we have a large armamentarium of treatments that are quite effective for heart failure. These are patients with heart failure with reduced ejection fraction, and you can see their 2-year mortality that is changed for the better with the implementation of all the therapies that are listed here. And I'm not going to spend time going through each of them in detail, but it's just we're fortunate in this field to have a lot of things that work, both medical therapies as well as device therapies. And for the purpose of this morning's discussion, I'm going to spend a few minutes talking about left ventricular assist devices, because you can see as we move to the stage D in New York Heart Association Class 4 patients, the 2-year mortality figures start to become very high. And so this is an area in which we really need to be thinking about the integration of palliative care and heart failure management in taking care of these patients, as opposed to the more mild forms of heart failure where we're trying to layer on more and more neurohormonal blockade. And with the left ventricular assist devices, we're going to be speaking about inotropic support some more this morning. But if you look at the historical perspective on patients who are very sick on intravenous inotropes, I mentioned the hospitalization confers about a 20% 1-year mortality. Being on IV inotropes is associated with a 50% 6-month survival. And that's largely the patients who constituted this medical therapy arm of the left ventricular assist device trials. And you can see with some of the early pulsatile flow left ventricular assist devices, there was a dramatic improvement in survival of these patients with end-stage heart failure. With some of the continuous flow devices, there's been a further increment in survival compared to the medical therapy arm. And so we spend a lot of our time trying to understand who are the appropriate patients to deploy mechanical circulatory support. Under the direction of Aaron Coglianese and Dave D'Alessandro here, our 1-year survival rate with patients that have VADs deployed is in the order of 90%. So very distinct from medical therapy for patients with advanced heart failure, but understanding who the right person is critically important. Currently, we think about assist devices in patients who are stable but inotrope dependent or patients that have symptoms at rest. Those tend to be the best candidates for this therapy. But again, this is a very dynamic field. So as the pumps get better, we anticipate deploying them earlier in the course of heart failure. But again, understanding who is the person that's going to do well with this device and who the person is that's going to survive in heart failure is very difficult. It's very different than advanced metastatic cancer, for example, that tends to follow a more linear course. If you apply heart failure survival models to patients with advanced heart failure, we do a pretty poor job of understanding who's going to survive and who's not going to survive. You can see the C statistic for some of the LVAD models is on the order of 0.6 to 0.7 for predicting prognosis. You can use the Seattle Heart Failure Score, where you can plug in all these characteristics of a patient, their age, what medicines they're able to tolerate, whether they have a defibrillator or not. But again, these metrics perform pretty poorly in the advanced heart failure patients. And so understanding the trajectory of these patients can be a real challenge, in part because we have these rescue therapies that are available for our patients now that can be deployed. And so one of the things that we focus on is trying to understand what the patient's frailty is that's going to respond to an intervention like an assist device or a transplant. Things like cardiac cachexia, for example, or progressive exertional intolerance because of cardiac dysfunction, or even some of the pro-inflammatory state that comes along with an advanced heart failure state. But we also need to take stock of some of the LVAD or transplant independent frailty that patients have with advanced heart failure. So advanced age, underlying other multi-organ system diseases. And these patients are not good candidates for some of these advanced therapies. And we have to understand what degrees of frailty are going to improve and not improve with some of these therapies that we now have available to us. And so I pictured one of our patients who was supported on an assist device actually for about 7 years in terms of some of the decision making between going down this aggressive course of action with an assist device versus focusing on inotropic support and hospice support. And it really involves a lot of decision making. I've highlighted palliative care right in front and center here, but it also has to do with the home environment, the support system, the patient's ability to tolerate one of these assist devices, and really the multidisciplinary approach of the palliative care team. We've been quite fortunate to have palliative care involvement with all of our patients that go for destination therapy assist devices over the course of the last several years. So I'm going to transition to Natasha now, who's going to talk some about this home inotrope program that she's been instrumental in helping to bring to fruition. And then we're going to hear from Cindy about Aldo Servino.
Good morning. So I just want to begin by talking a little bit about inotropes. I'm sure a lot of you are familiar with them. We use them in our patients on a daily basis. And they're essentially drugs that improve the contractility of the heart. They work on different receptors, but with the same ultimate goal. One of the oldest inotropes, digoxin, was actually the discovery is accredited to a British physician in the 1700s who had a patient with edema presumed due to heart failure. And he found that using digoxin, which is actually extract of a foxglove plant, improved her edema. In terms of these inotropes, the majority are IV, and we often see their use in the ICU, dopamine, dobutamine, and milrinone. There's really very little data out there about the long-term use of inotropes, and in fact, most of the data that is out there is for ICDs, who are a standard of care for patients with heart failure. A newer medication, omecamtiv mecarbil, is currently in phase 3 trials, but the data for that isn't expected until 2021. So I'm going to talk a little about milrinone. This is the inotrope we use most commonly at MGH. In fact, one of the infusion companies did a retrospective review over the last year and found that 80% of their patients were on milrinone, which sort of is very similar to our use at the MGH. So milrinone has been used for almost 2 decades. We dose it as mics per kg per minute. The range is 0.1 to 0.5, and we find that most of our patients end up somewhere in the middle of that range. A question that does come up frequently is, should we adjust the dosing? A lot of our patients have cardiac cachexia and can often lose significant weight over time. For the most part, we've been keeping that as the same. So one thing to take into consideration, it is renally cleared. A lot of our patients do have underlying kidney disease, and so this is something that we need to be aware of. Milrinone is generally quite well tolerated, but like all medications, there are adverse effects, the 2 most common being hypotension and arrhythmias. This is particularly pertinent. A lot of our patients have ventricular tachycardia and atrial fibrillation, and obviously the milrinone can exacerbate this. There are really 2 trials that discuss the use of inotropes, and like I said, this data is quite old. The PROMISE trial in '91, which was published in the New England Journal, looked at oral milrinone, and the study was actually terminated prematurely due to an increase in morbidity and mortality. And then slightly more recently, although still 16 years ago in JAMA, the OPTIME CHF trial looked at patients who were getting 48 to 72 hours of milrinone. Again, they found no change in mortality. There was perhaps a reduction in hospitalizations, but again, the data wasn't particularly positive. And since that time, there really hasn't been much. A retrospective review published in Circulation in 2015 suggested that perhaps the data was in fact better than previously suggested, but that there was definitely a lot of work to do in this area. So the ACCF and AH guidelines for heart failure talk about inotrope therapy. They say that it's reasonable as a bridge therapy while awaiting MCS and transplant, and this is a significant proportion of our patients. The other proportion are those who, for whom inotrope therapy is really a palliative measure, those who are not eligible for advanced therapies such as LVAD and transplant, whether it's due to age or other comorbidities. So I'm going to talk a little bit about home inotrope therapy. This picture here is an example of what the home infusion pumps look like. So patients on home inotrope therapy have a life expectancy of about 9 months, and only 1 in 4 survive to a year. So they're very strict Medicare coverage guidelines about which patients are eligible, and these have to be very well documented in the patient's medical record. When we came up with our own guidelines, a lot of these were based on the Medicare coverage guidelines. So there are 2 infusion companies that we use at MGH, Quorum, which is part of CVS Specialty, and then New England Life Care. So milrinone is expensive. There's a big range of cost, and most of this is due to patients' insurance, whether they have a commercial insurance or Medicare. But even at the cheapest price, it still costs over $5,000 a month, which for a medication where there really isn't that much data to support its use, it's obviously quite expensive. So we came up with our home inotrope guidelines in June of this year. We found that there was really little consistency between providers providing care of these patients, and we wanted to come up with a set of guidelines to allow the best care for these complex group of patients. So the guidelines are divided into really 3 main parts. The first is candidate selection, which I'll talk a little bit about, then the implementation, and then finally the disposition and follow-up, which is sometimes part of the most challenging aspect of this. In terms of disposition and follow-up, usually it's either as a bridge to LVAD or transplant or to palliation and then ultimately hospice. So the first part I want to talk about is our selection criteria. So patients must be a New York Heart Association class 4, so essentially having symptoms at rest. These patients often have a high symptom burden. They have dyspnea, fatigue, very limited exercise capacity. A lot of our patients will have cardiopulmonary exercise testing, and they really have, a very low ability to do activities. The other thing is a lot of our patients have frequent hospitalizations, and we find a lot of our milrinone patients have had at least 2 or 3 hospitalizations within the last 6 months to a year. A lot of the patients also have cardiorenal syndrome, which is essentially kidney dysfunction as a result of being in heart failure. And Aldo, who we'll talk about, actually really benefited from this. We were able to significantly reduce his diuretic dosing after we put him on inotropes. We also have to have objective data that we are, in fact, improving the cardiac index. So all patients will go to the ICU. They have to have a PA line in place so we can prove that the inotrope is actually helping them. And then, like I mentioned, the 2 main side effects, hypotension and arrhythmias. For the most part, patients tolerate it quite well, but again, they need to be able to prove that, and we keep them in an ICU setting to make sure that they are able to tolerate it. And then the other considerations, which I find are some of the more challenging ones, and perhaps even more important. So patients need to have social support. Going home on inotropes can be a huge burden in terms of managing the pumps. They need to be able to change the bags. The other consideration is disposition. So very few rehabs are comfortable taking patients on inotropes. Skilled nursing facilities almost will never take patients. We've had some challenges getting patients to hospice, and part of that is due to the financial costs of this. Most patients cannot afford to pay out of pocket, so they really need to be covered by insurance. And these are things that we want to establish prior to discharge from the hospital. So when we go about starting a patient on inotropic support, there are various things that go into it. Our case management colleagues have been absolutely wonderful in helping everything from referral to the VNA, sorting out insurance. They've been, paramount in allowing these patients to go home safely. All of our patients are seen by palliative care. At this juncture in a patient's care, it is really imperative that they're seen by the palliative care service, whether it's for symptom management or to assist in the future transition to hospice. All patients have to have a goals of care discussion, which has to be documented in the medical record. And leading on from this, all of our patients complete a MOLS form prior to discharge. In order to provide an additional layer of support, we ask our social work colleagues to see patients who have been particularly helpful in supporting the caregivers of these patients. And then we created an expectation form, which was actually based off the LVAD expectation form, about what we expect from our patients and also what they can expect from us as a program. So one of the most challenging parts is the transition from hospital to home, and our goal is to always make this transition as seamless as possible. So the first thing is every patient is assigned a care team, which is comprised of a nurse practitioner and a heart failure doctor, and these will follow the patients longitudinally. Every patient is given an inotrope card. We found that patients were getting admitted to outside hospitals, and often providers there were changing doses and things like that. So patients are able to carry these around in their wallet, and on the back it has emergency contact numbers if they do end up at other institutions. Education is also extremely important. The infusion companies and the nurses have been really helpful in helping to educate the patients and the support persons, making sure they're able to use the pumps and are confident going home with this equipment. And then outpatient follow-up. All of our patients are seen within a week to 10 days in our heart failure clinic, and then they'll see the attending within a month of discharge. They get frequent labs, often twice a week to begin with, and then going down to once a week when they're more stable. So I'd like to talk a little bit about palliative care and heart failure. So the World Health Organization definition is palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. And when I read this, it really struck me that this is, in fact, as heart failure providers, what we do every day. We are, in fact, palliative care providers. The ACCF and AH guidelines have palliative care is effective for patients with symptomatic advanced heart failure to improve quality of life, and it's a class 1, so the highest level of evidence. So what is palliative care and heart failure? So like I mentioned, these patients have a huge symptom burden. It really affects all organ systems of the body. It affects them physically, it affects them psychologically. The other thing is a lot of these patients are encountering significant amount of loss in terms of their independence. They often have frequent admissions, they have frequent clinic visits, they require frequent lab tests. It's a huge burden on the caregivers. And so palliative care have been instrumental in supporting these patients through a very challenging time. And thirdly, palliative care is extremely helpful in advanced care planning. There's data out there to suggest that having advanced directives early on in the care actually not only reduces hospital costs and spending, but it allows patients to spend the rest of their time hopefully outside the hospital and at home. So this is an interesting study, the Palliative, which was out of Duke, and it was a randomized trial which put patients into two different groups, usual care and then usual care plus a palliative care intervention. And this intervention, each patient was assigned a special palliative care nurse practitioner. There was also chaplain resources. There was mental health providers available if necessary. And they looked at various quality of life scores over a 6-month period. So this study showed that palliative care was beneficial for quality of life, anxiety, depression, and spiritual well-being. Rehospitalization and mortality were not affected. The other interesting thing to note is 30% of patients actually passed away within that 6-month period, which I think speaks to how sick this patient population is. So what are the challenges with heart failure and palliative care? Well, as Dr. Lewis mentioned, prognostication and disease trajectory is unlike other diseases. So if you look here for cancer, there's often a plateau phase and then patients decline, whereas in heart failure, you have these periods of stability punctuated by these periods of rapid decline. So when to involve palliative care is often a challenge. The other thing that makes prognostication even more difficult is we have a rapid evolution of therapies. We have percutaneous valve replacements, which are being performed by our interventional cardiology colleagues. We now have CRT devices, we have organ transplants, we have ways of increasing the pool of organ transplants, and these efforts make it even more difficult to prognosticate. And finally, like anything in medicine, there's often a lack of, there's a big lack of palliative care specialists, and they're not always available to see the patients. So when is the right time to involve palliative care? I found this quote, which was a commentary on an article published in JAMA. While we never say never in medicine, it is never too early to start the conversation. So heart disease is the leading cause of death in the USA. But interestingly, when you look at the principal diagnosis for hospital admission, 27.2% was cancer and only 18.8% is heart disease. There was a study looking at the Get With The guidelines. They looked at 122,000 patients who were discharged between 2005 and 2014. And in fact, out of all those patients discharged with heart failure, only 4% were transitioned to hospice, which I thought was actually a remarkably low number. So I'd like to move on to talk about Aldo. Aldo is one of our favorite patients. We took care of him for a very long time. So just to give you a little bit of a background, like Dr. Lewis mentioned, his cardiac history really dates back to the 1980s, where he suffered from 3 heart attacks. He lived with ischemic cardiomyopathy for a long time. And like a lot of our patients, he had many other medical issues. He had kidney disease, he had diabetes, he had a seizure disorder. He also had bladder cancer, for which he was treated. So Aldo was married to Cindy. He had 5 children. He did have a remote smoking history. He actually emigrated from Italy in his 40s, and he was an artist and an avid cook. So like many of our patients, he was on 20+ medications. A lot of our patients have an extremely complicated medical regime. So Aldo was followed at MGH since 2002. Dr. Lewis, Dottie Sullivan, and Dr. Seiss from nephrology were 3 people really instrumental in his care. Whilst going through Aldo's chart in preparation for this talk, I came across this quote from 2002. So all of these medical problems have taken their toll on Mr. Savino. He is as active as possible, but both his physical and emotional reserves are somewhat limited. His positive attitude has helped him to persevere in spite of the adverse effects of his medical problems. And I really think this speaks to Aldo. So Cindy documented his course very well. His first admission was in April 2017, and prior to that, he had actually done very well at home. He came in with heart failure, he had some acute kidney injury, and he also had aflutter. He declined a cardioversion at that admission. So we consulted our palliative care teams. He'd really had a decline in his ability to live his life, and we felt that this was an appropriate time to have them see him. So these are a couple of quotes from the palliative care note. So Aldo and his wife understand that heart failure is really a terminal diagnosis. They felt that he had done quite well prior to this. They felt that this hospitalization was useful. He felt much better after diuresis. And Aldo had an interesting relationship with palliative care. He often was quite hesitant to discuss goals of care and things like that, but he did promise us that he would continue to think about it, but hadn't made any decisions at that time. So Aldo was discharged, and he did relatively well until December, when he unfortunately came back in with a similar presentation. Again, he came back in with heart failure, his kidney function was worse, and he was also falling at home. We got an echo this admission, which showed an ejection fraction of 24%. He also had some aortic stenosis. Cindy took pictures documenting his course, and this is one of the pictures of our team rounding. He called us the cardiac army, and so this was one of our visits to see him in the morning rounds. So he went to the ICU where he had a PA line placed, which showed that he had high filling pressures and a low cardiac index. He was started on milrinone at a very low dose, 0.1, but felt remarkably better with it, and his kidney function improved significantly. So Aldo then went back to the floor. This is his nurse, Brian, doing some walking around the unit with him. He had a PICC line placed. Like I mentioned, his diuretic dosing was significantly lower than it had been previously. He finally did sign the healthcare proxy form, and we placed a referral for outpatient palliative care. So he saw palliative care twice in the outpatient setting, first in January and in February. And if you look from his first visit to his second visit, I think it was becoming quite, real to him that this was what he was going to be on for the rest of his life. He wasn't afraid of death, but he was worried about suffering. He did have issues with his mood, which took away his energy, his appetite, and interest in activities. He was aware that milrinone was really the last option, but he felt thankful that he was able to have some more time. In February, he notes that he did remain quite depressed. He often said he's not afraid he's going to die, but in conversations with Cindy, he probably didn't actually believe that he was really going to die. And I thought the last comment was quite poignant. He says he would like to avoid suffering, but however endorsed that he was suffering now from the necessity of being on milrinone and the limitations in his activity. So here are some pictures of Aldo. He was able to go home between March and April. He had a wonderful VNA who took great care of him. He did come in to get some iron infusions, which gave him a little bit more energy. And most importantly, he was able to spend quality time with his family, in particular his grandchildren. So by May and June, July, he was able to get out the house. He was going grocery shopping, which he loved, trying to shop with healthier choices, which I know Dottie was a big proponent of. And then he was able to go out for lunch with his wife, Cindy, in July. Unfortunately, in August, things started to take a turn for the worse. This was an email from Cindy, who felt that it was time to have his medications reevaluated. He really felt worn out and weak. Small things seemed to get the better of him, and he was sleeping a lot. So his last clinic visit with the heart failure team was in August the 15th. So at that time, his huge complaint was fatigue. He really felt that he wasn't able to get out much, and he had had a significant decline in his energy levels. So on September the 3rd, this is a note that's documented in Aldo's chart from his VNA. I just received a call from Cindy Sabino that Aldo passed away in his sleep yesterday. I told her that what he had, everyone dreams of: love, happiness, and family, and now peace. And this is a photo of Aldo the night before he passed away, actually making homemade spinach ravioli. So one of my favorite photos. And with that, I would like to hand you over to Cindy, who's going to talk a little about her experiences taking care of Aldo.
So thank you for having me. I think Aldo would be really proud to have been a part of this. So as an introduction, Aldo's attitude towards palliative care in general was very challenging. He never would sign any end-of-life directives, a do not resuscitate order, nor would he consider the 5 wishes. He did very reluctantly sign a healthcare proxy one day, and I think he might have torn it up if he'd been reminded that we had it. You know how resilient your cardiology patients are. This one truly was not going to die. He was a tenacious optimist and survived 3 heart attacks 30 years ago. His middle one caused him to go into complete heart block twice. Aldo came into the hospital at 87 with heart and kidney failure, and he was so weak that he'd fallen twice in 3 nights at home, and I needed to call 911 to help lift him. I couldn't get him up, and his legs weren't strong enough to get up from the floor. So we came into the hospital December 16th. We never quite told, I don't think, Aldo, that milrinone was end-of-life care or palliative. On the day of discharge, January 3rd, I was taught how to run Aldo's infusion pump, how to clamp and release the cassette that attached to it, and given written instructions. Aldo was sent home with a pump running and a 48-hour supply of milrinone. New England Life Care delivered our first box of of supplies the next morning. Every week, I counted up the supplies on hand and went over New England Life Care's cardiac assessment with Gina, our patient representative. The assessment, I brought a copy of it if anybody wants to see it later. It covered changes in weight, changes in medication, falls, if any, the time we actually changed the infusion at home, doctor's appointments, any problems we might have had with the equipment, and any questions we might have had. Aldo continuously lost weight, some weight, and Dottie Sullivan reported that the pharmacist from New England Life Care often called to check in because his weight affected his dosing. If we ever ran out of supplies for any reason, I could call Gina, our rep, and she would get them to me the next day. She'd usually send them out UPS. The pharmacy used couriers, and they came to the house, came right up to our apartment door with a big insulated box full of the Milrinone with an ice pack, and then it went directly into the refrigerator. Once in a while, the visiting nurses would come across broken stat locks or missing parts in the PICC line dressing kit, so that was always solved really quickly. Milrinone came in measured dose IV bags. You may already know a lot about this, but the bags, each bag was labeled with Aldo's name and prescription. Tubing, a cassette or the pump clamp, a pinch clamp, and a capped port that went to his PICC line clave were all set up, primed, no air bubbles, ready to install. It turned out there was no extra Milrinone in the IVs. The supply lasted exactly 48 hours with no leeway on time. 11 p.m. was our favorite time to change the IV because we were always sure to be home, and it gave us more freedom. New England Life Care has a 24/7 support. Whoops, I flipped your slide. New England Life Care has a 24/7 support with a nurse on call. When the infusion line accidentally caught in a wheelchair at the hospital, we didn't notice. There was no way for a cut line to set off an alarm. And I stopped at the supermarket on the way home. So Aldo had been without his medication for at least an hour. So I called. The nurse on call told me that Milrinone is very slow acting and there shouldn't be a problem. And they also covered an extra bag of Milrinone so that we could get back to the time frame that we liked, 11 p.m. So they were incredibly helpful and responsive. Routine operation. Do I want to go over all this? I probably get it. Yeah. Do it? Don't. So I did write out how the pump operated and how we set it up. It got to be really routine. We had 2 pumps and we rotated them. It was impossible to deprogram the pump. It was quiet. It worked in any orientation, so upside down, lying down, straight up, and it survived quite a few drops. It came with a carrying case that you saw in some of the pictures, and if we went out, Aldo usually wore it around his neck. At home, he kept it in the basket of his walker or beside him on the couch. The pump had alarms. One if the medication ran low or out. Excess pressure triggered an alarm if a pinch clamp was left closed, or if Aldo leaned on the line, or bent the line when he was sleeping. Flow would be restricted and the pump alarmed. Moving his arm would stop it. Aldo's PICC line had a second backup line in case of failure. So we flushed that backup line every day with saline and followed that with heparin. That came all pre-measured in syringes with a little screw cap that went right onto the clave of the PICC line. And then we had these little green caps that we covered the line with. Of course, we cleaned the surface we were working on and used alcohol preps that they sent us. The medication line, it was really important. It was never to be flushed because Flushing it would have rushed a big dose of milrinone right to Aldo's heart. In 8 months, we never had a problem with either line. We had weekly visits from partners visiting nurse Mary Galluccio, who changed Aldo's PICC line dressings once a week. Mary asked for IV 3000 dressings that were less irritating to Aldo's skin, and the pharmacy stocked them. Other care at home, having a visiting nurse in the partner's system was a huge benefit. Mary was great about communicating, and she could routinely check Aldo's INR and often did blood draws in preparation for Aldo's clinic visits. We also managed Aldo's diuretics at home, weighing Aldo every day, balancing his torsemide with a low dose of metolazone as an override. Mary actually figured out that excess mucus and Aldo's cough were telltale markers that Aldo was ready for a little extra diuresis. She also managed occasional venous stasis ulcers that Aldo got on his shins. So the outcome, Dr. Moyer, Aldo's primary care physician, had called Aldo a miracle 5 years ago. I wish you all could have seen Dr. Moyer's reaction at her first visit with Aldo after he started milrinone. She stood up, beaming, and applauded you, the cardiology team. Aldo regained his energy and overcame his deconditioning to the point where in April and May he was able to go back to shopping at the supermarket using just a cane and the shopping cart. That was Dottie Sullivan's goal for him. That brings up a very special, huge thanks to Dottie, who saw Aldo for years, most recently in clinic once a month. And Dottie, who so graciously was so very careful to hedge when we started asking for another miracle, for another boost, when another boost just wasn't possible. I helped Aldo fill out a questionnaire for Dr. Lewis about his experience with milrinone. Without any prompting, I just read him the questions and helped him answer it a little bit, but I didn't prompt him, and he was extremely positive, saying that he would highly recommend his treatment for anyone who needed it. In my experience, I don't really think that Aldo was depressed, and if he was, he kind of had that great ability to bounce back. I think he always had hope for the future. Aldo lived exactly 8 months to the day from his discharge January 3rd. Toward the end, Aldo was becoming somewhat weaker and sleeping more, and he was having less response to the metolazone boost to his diuretic loop. I can say he was very comfortable, and he was never so weak that he fell again. Aldo loved to cook and cooked an amazing dinner the night before he died. Aldo's heart came to an electrical standstill while he was napping, so I totally believe that his death was completely unrelated to his milrinone treatment. He was truly in control, comfortable, and as active as possible, and in peace. So I wish there was more time because I could thank people individually, but I just had a few thoughts about some support that we got along the journey. And this one goes back 30 years. Dr. Shippen Lee, a Mount Auburn Hospital resident, followed Aldo. He told me when I was curious, he said, it doesn't matter what you were doing when you have a heart attack. If you have heart disease, you're probably going to have a heart attack. Everybody can have a fight one day. It doesn't mean that because you were fighting, the person had a heart attack. So exactly what we were doing wasn't the cause. We just happened to be doing something that was a lot more fun than fighting. That's why I was worried. I met our partner's physical therapist, Trudy Mulford, in the parking lot one day. Physical therapy wasn't a whole lot more successful than convincing Aldo to sign things for palliative care. I had to tell her that Aldo wasn't doing his exercise when Trudy wasn't there. Now, Trudy has rather unique vision, and she said, it's emotional ping pong. And she added, you never want Aldo to be afraid to see you coming around the corner. Emotional ping pong. Aldo liked to have control. So many times I whispered emotional ping pong to myself as I was feeling frustration, and I was able to let it go for Aldo's sake. Closer to the end, Mary Galluccio, our partner's visiting nurse, was considering coming twice a week for extra moral support. Mary never went out the door without saying, call me anytime. And she really meant it. She meant it and she lived it. And my lesson kind of ties into the title of the program, the Undulating course. Never let a bad day or two overwhelm you. A little rest and a break may make all the difference. That spark of optimism will return. In December, the week Aldo had fallen twice and was so weak, I reached out on Gateway a little too late on a Friday afternoon. Dr. Megan Size, who saw Aldo for his kidney failure, called me back. She said, can you get through the night? I said, yes. She said, bring him in tomorrow. I think we can do something to help him. And indeed you did. I'd love to thank you all individually, but there are time constraints and it took more than a village, it took an army. Thank you doesn't begin, so maybe a few words snitched from Dr. Seuss can explain it best. Unless someone like you cares a whole awful lot, nothing is going to get better. It's not. So thank you to all of you.
So I'd like to take a moment to thank Cindy. She was the most wonderful carer of Aldo. He wouldn't have been able to have been home for so long without her. She was extremely diligent in everything that she did, and we are truly grateful for everything that she did for Aldo, and also it was a pleasure getting to know her and Aldo over the course of her heart failure. So just a little, just to wrap up, to talk about where do we go from here. So in terms of incorporating palliative care into heart failure, we've been doing more and more of our patients having seen the inpatient palliative care team. As always, we use this opportunity to take a multidisciplinary approach to our patients using social work and chaplaincy. We're in the process of creating a combined heart failure and palliative care clinic, which is in the works as we speak. We're also starting to educate our heart failure providers. Dr. Colanisi and I are going to the PCEP course next week, and we hope to get training in palliative care and how to provide palliative care to our own patients. Advanced care planning, like I mentioned, is always very important. The Conversation Project is a tool that's been provided to help patients decide what they want for their care. And like everything, there are always opportunities for research, and I think this is really important in order to make sure that we provide the best care for our patients.
So we'd be happy to take any questions. I want to revert back to one of the slides I showed in terms of predicting outcomes in heart failure. And one of the things that doesn't go into those models is the social support system at home, and particularly loved ones that take care of these patients, which factors extremely strongly in patient outcomes. And obviously Aldo was incredibly lucky to have Cindy by his side throughout all of this. So happy to take any questions that anyone may have.
Cindy, thank you so much, and thank you to all of you. This was an amazing presentation. Cindy, the question I have for you is, how different was milrinone therapy than you thought it would be when the team talked to you about it before you and Aldo went home? Because what I hear you talk about is something that was very technical, and you had to learn a lot, and it sounds like it was almost like a full-time job. So how was it different than what you had thought before you went home?
I think Aldo's daughter, English was Aldo's second language. And I think he did remarkably well to understand things. And his daughter, Marta, did some medical translating. And Marta, much earlier in her life, had cancer, and they put a port in. So Marta told Aldo in Italian that that was what was probably going to happen. I don't think he realized, because he was pretty resistant. So he probably didn't realize quite what was going to happen in the ICU and that he would go home with that line. But then when he started to feel better, he was so positive about it. So he really bounced back. So it was kind of mixed with him.
Okay.
Other questions?
Thank you so much, all of you, for this presentation, which has been extremely helpful. I'm curious if there are any mechanisms you guys know of to get inotropic support or LVADs for undocumented immigrants.
So we've performed left ventricular assist device supports as well as transplants for undocumented immigrants. So we typically will take care of patients, you know, in the context of their need as opposed to their means. So one of the things that's important is to secure some form of, you know, coverage. Obviously, Natasha shared some of the costs related to some of these advanced heart failure therapies, but I think that the proof is in the track record. So we've done this for patients. It is not easy to navigate home milrinone, as Cindy, you know, nicely articulated, and so sometimes it serves as a somewhat of a testing ground for how patients are going to do with advanced therapies, because once you put a left ventricular assist device in somebody, it's not like starting them on a medication and then understanding, you know, that they're not going to tolerate it and then stopping it a few days later. You know, this is an irreversible, essentially, intervention for somebody. And so sometimes we do start people on milrinone, and I've had patients come into my clinic, including, you know, some that fit in the category you just described, who will come in for their first visit and their pump will be disconnected and they will have not been on milrinone for days, and they will, you know, be in cardiogenic shock. And so some of it is a matter of their kind of social support system in terms of, in their ability to understand how to administer this, in terms of some of the, you know, barriers that can come up with regard to educational status. But, you know, we don't ask people their citizenship when it comes to their VADs or their milrinone. Yeah.
Cindy, I suspect that Aldo, when you had some tough days, what strength or resources helped you cope with those times? Can you repeat that so folks are here?
Yeah. So Cindy was asked about the, you know, strengths and what she drew on for this challenging course with Aldo.
Well, I really think we had great support all along the way. I used Gateway a lot. Maria and I are pals. And our visiting nurse really did say, call me anytime. And we did call her one Sunday, and she was out picking apples with her boys, and she answered the phone, and Aldo was having a little trouble breathing, and I can't remember what she told us to do, but she certainly calmed us down. So we really felt that we had people to reach out to, and a great resource at New England Life Care, because they were on call. They had a nurse on call 24/7, and I think Dottie was really accessible, and Dr. Lewis and Natasha, who really did all this behind the scenes. And so I always felt really supported. His primary care doctor was great. I went to see her after Aldo passed away and to thank her. And I told her a little bit about what happened, and she waved her arm like this, and she went, well, Aldo wasn't going to die. In response to his reluctance to entertain palliative care. And then I told her he didn't do his physical therapy, and she waved her arm like this, and she said, well, he could paint, he didn't need to. So I've just felt so supported. I mean, some of those things that I read you, comments people made, really made a huge difference. Emotional ping pong was a great thought. So we were helped all along the way. I really feel like we were blessed.
I'd like to open it up for any questions at our remote sites.
I did bring this along. This is how I kept track of all those meds. Shouldn't get too far away, but it was a challenge. And because all his meds were reduced after he went on milrinone, there were a lot of pills to cut in half. Of course, we had to track his diuretics, so every day I just checked them off.
You're giving us quite an education, Cindy.
That was really helpful.
Greg and Natasha, could you comment a little bit about what your experience is working with hospice? Because one could imagine that, you know, folks who are on home milrinone therapy by definition meet a criteria for hospice, but then there's the concern about what the cost is, and with this undulating course makes it very difficult. And it just is helpful for us to understand where there's room for improvement, or what those challenges are that you face in working with a home-based hospice program.
So it's an interesting question, and actually I think things have changed since we initiated our inotrope protocol. So when we began, we found that hospices were really reluctant to take on patients on milrinone, and primarily for the cost. But knowing the right people and knowing who to call, we've almost always managed to get our patients onto hospice. There usually has to be a determined end time. So if this is a patient that we expect to live for many months, the hospices don't want to take them. But if we have a defined period, often we have patients who have a specific family event or something they want to live to. They're agreeable to take them for that period of time with a very strict plan to wean. But cost has really been the main, yeah.
Thanks. I think Natasha brings up a good point, cost, and I think recently the milrinone has come down so that many hospices will actually be able to cover the costs. So fortunately, many of our local collaborators will be able to take a patient on. I think what they worry about is the patient who comes on who you guys do such a good job and lives 18 months versus the patient who they see a clinical decline and know that this will be maybe a matter of months or certainly about 6 months. The only time when many people will look to a clearly defined endpoint is if a patient is transitioning to one of the hospice residences, and usually then that's when they have a defined wean requirement, at least for one of the hospices. One hospice actually struggles with the milrinone cost and will actually ask to be transitioned to dobutamine. But I think this is hard, and I think, as Natasha said, it's knowing who to call to actually have that warm handoff and sort of why now, and is there going to be an endpoint. But I don't think, not everyone requires there to be a wean time or a specific endpoint unless the plan is to transition to the residence.
I think a lot of it as well is hospices, or a lot of people are not very familiar with using inotropes, and we found even with the VNAs that they're very hesitant, they don't have a lot of experience, and there's sort of this association of this kind of scary medication. So I think as we see more patients on it and people become more comfortable, I think it will be easier to transition patients.
Well said. One of the reasons to have this pathway in place, I think it's been helpful, up on Ellison 10 and Ellison 11 in terms of getting people into the pipeline for a regimented approach to implementation of the home inotropes. And part of that process is understanding, we've summarized the case this morning where the inotropes are very helpful, but we certainly don't want to paint a picture that this is a success story with every single person that goes on to milrinone. So it's important to navigate a plan for what is going to happen based on how a person responds to the inotropes. So, that is best, and obviously we appreciate the assistance of the palliative care service in doing so, because part of that is not always articulated. Sometimes it's you can get somebody started on milrinone, but then what happens? If they're having ventricular tachycardia related to their milrinone, or if they have progressive heart failure with the expedited course that milrinone sometimes results in for the progression of their LV systolic dysfunction. So it's important as part of having a formal kind of regimented process to plan for what happens if the milrinone doesn't work. And I think that's part of this process of having a concerted effort around the program for the home inotropes.
I think too the cardiac assessment that we went over. I know the pharmacists reached out often to double check. So if they had seen anything in their questioning that was concerning, they would contact me.
I was just curious, and we've seen with the LVAD implantation that earlier in their heart disease trajectory, that they do better. Is there any correlation with milrinone therapy? Do they do better if we started earlier? Do they have a better success and a longer life?
I just want to make sure I understand your question. Do you mean if the LVAD is started earlier in the course of heart failure, or?
I mean, it seems like the LVADs have been implanted in some cases a little bit earlier, and then the patients do better. They have a better quality of life. They live longer. I'm just curious if there's any correlation with the inotrope therapy.
Oh, I see.
That people do better and live longer and have a better quality of life.
Yeah. So it's important to also point out the fact that inotropes are used only when patients are in kind of a hemodynamic phase of decompensation in their heart failure. Inotropes are known to be associated with poor survival, so we know that we should not, if you just started somebody with moderate heart failure on an inotrope versus not. So they really should be used only in patients who are really at the end stages of heart failure. As far as deploying left ventricular assist devices, Aaron, do you want to comment on the VAD program? Because this has been an interest of Aaron's in terms of the timing with which we use VAD.
How are you doing here? I have one of those.
And so LVAD research has told us patients do in fact do better when we catch them at a point where they haven't quite fallen off the cliff yet. And then ultimately LVAD therapy is associated with improved longevity in patients with heart failure. Whereas the inotropes do increase myocardial oxygen demand and ultimately do have sort of an accelerating effect in some circumstances. So they're really sort of a last-ditch thing. So a little different there.
And we'll end there for the sake of time. Thank you so much, Cindy, Natasha, and Dr. Lewis.
Oh, yeah.